Okay, we're going to talk about the revenue process in this module. This is module 6. The modules of the life cycle of the healthcare dollar, the practice models, credentialing, managed care, and the charge master are all pieces that as we go through this, you're going to get a chance to see how they fit into the puzzle. So we've kind of gone through those other modules specifically leading up to so that when we go through the whole revenue process, you see where those segments kick into the actual process. Learning objectives, pretty straightforward. We're going to take a look at the process. We're going to take a look at the elements of the process and kind of work our way through exactly what that means. There are 8 steps to the revenue operations workflow, or the revenue process as we call it. And that starts with scheduling, putting people on the schedule. Census means they got admitted to the hospital so they can be in NICU. Virtual registration, you had to go through registration, you had to fill out paperwork, sign your life away. Time of service is actually the clinical event. The charge posting is claim charges going out, payments coming in, payments that didn't come in, we work through third-party recovery. Patient balances then go to the statement process, and then we have a QA and audit compliance over top of all of that. So that kind of walks you through the 8. Now, clearly, we're going to spend a little bit of time on each element of that process, but those are your 8 steps in the process. So if you're in a practice, you're setting it up, you're going to have goals that you're going to establish or characteristics that you're going to look for when you set up your process. Obviously, you're going to have an infrastructure that's strong. If you don't have the technology infrastructure and it's not stable, and you don't have standardization of how you apply standards consistently, that's going to create a breakdown and a revenue loss. You're not going to spend a lot of money trying to collect, because the object is that you want to minimize the cost of collections, and that's by avoiding hurdles and creating extra work for yourself, focusing on things that should be done in each step of the process so that you're not spending more time on the back end. You're going to look for standardized lines of accountability. You're going to make sure that the process is empowered for patient satisfaction, that when a patient calls to get their bill resolved in your business office, they're not transferred around to 9 people and you got to talk to the supervisor and God and everybody else just to get something done. You don't want that. You want people empowered to make sure patients are satisfied, and obviously recognizing who your customers are and the communications. So those 8 steps we kind of look at as a circle. We start up in scheduling and kind of work our way around the circle, and when we're done, we should have a lot of money. So let's start at the beginning, which is going to be census and scheduling. The census management, we're going to look at patients got admitted to the hospital. We're going to look at how we do files. We're going to look at getting people in the door. So this is your first impression. If someone calls up to schedule an appointment and they're a new patient and they say, hey, I'd like to schedule an appointment. Hey, hold on a second. I've got someone else on the other line. That's not a very good first impression. So I'm a big fan of some centralized scheduling functionality where when that inbound call comes in, they're just treated. We want to see you. We're so glad you called. Let's take a moment. Let's find out why you're coming in. What's your chief complaint? What are you coming in for? Let's grab an appointment type that has an allotment of time that will make sure that you get yourself addressed. And in fact, did you know you don't need to call us anymore? We have an app. You can actually schedule online. There's apps that allow you to schedule, or you can go to your patient portal through your electronic medical record and you can request an appointment through there. And so we start looking at things in that regard. At how do we make marketing of our practice to get people in better? Recall management. If I'm going to call you back in for an appointment in 10 days, in 6 months, or come back for your annual, why am I putting the burden on the patient? They're money to me. So recall management is a process where let's put them on the schedule so that when December of next year comes up, all of a sudden my scheduling staff get a roster of 33 patients to call with a reason code that says, hey, Ken Klingensmith, we want to have you come back in. We need to get some lab work done, and it's your annual physical. It's been a year since you've seen us. We care about you. You come in and see us. Dentist got it down. So we in the medical practice need to get it down too. We also are going to be looking at balances. If you have patient balances and you need to go to your collections and you're trying to schedule an appointment, hey, hold on a second. I need to get you over to the business office before I can actually get you on the calendar. Now, on a hospital side, what am I looking for? If I'm in an emergency room, I'm going to want to make sure I get a census of everybody that was in that emergency room and seen by me so that I can make sure my business office, and this is kind of a step in charge posting, make sure that there's a charge existing for every patient that was admitted in that ER or on the ER census. I'm going to want to make sure that I, as a healthcare provider who's responsible for generating revenue, has a charge that has been billed out for every baby that was in that NICU. Because if we see a child and we don't bill a service, that's money you're taking out of your own paycheck, or the hospital's losing revenue because of it. So the census and scheduling is why I use that term in there. Obviously, when we talk about recalls, if I scheduled you right now for an appointment 1 year from now, chances are you're going to cancel it, you're going to reschedule it, or I'm going to send you an appointment reminder 2 days before your appointment. You're going to be like, oh my God, I can't go to that, and then blow me off. That's another reason for recalls, is to try to make sure that I don't have a discrepancy. I don't have people just not showing up for their appointments. I don't have people canceling and rescheduling. And that we actually will have an engaged patient, which is part of Meaningful Use Stage 3 in my process. So there are tools at scheduling that help us make sure we don't have no-shows, that we don't have cancellations, or at minimum, those are really controlled and managed. So I call that our first step, which is the scheduling process. Now, once you're scheduled and you're on the calendar, now it goes over to like pre-service work. This is where in a hospital, I've got you scheduled for surgery, and you know right away you're going to be expecting a call from the business office to say, hey, you're coming in. I want to know what your insurance is. I want to know how you get a plan pay for a visit. I want to get a deductible from you. I need to get a credit card on file. I need to make sure that when you come in for your elective service, we got all our ducks in a row. Or if you're in an emergency room, once you're triaged and seen by the physician, who's standing at your bedside smiling? It's the admissions office going, hey, let me see that insurance card of yours. Let me see your demographics. Give me your driver's license, because I now need to register you. You got on the schedule or in the census. You got back here. Now let's go through the process of getting you registered. Physicians' offices should run the same way. Schedule it. Love you. Great. So happy to see you. Expect a call from our pre-service office or our virtual registration to make sure we spend some time. In fact, can I transfer you there now? Or what's a good time that I can schedule? They can call you to basically get your insurance, verify your eligibility, check your benefits, make sure you understand what's covered and not covered. Make sure you know, here's the point, providership and credentialing. Are we on your network? Are we in your plan? Is the multi-plan card actually have the multi-plan logo that's going to help us to make sure I know what I'm going to get paid, and then in turn what your responsibility is? In fact, let me calculate that for you so there's no hidden surprises. Hey, wait a second, you're coming to me as a specialist, and I'm a nurse practitioner working in a specialist office. You need a referral from your PCP because you're on an HMO plan, and those are guidelines of what your insurance requires. Well, boom, medical management obligations. I can't let you come in until you get that referral. I can't let you come in until you give me $500 that you're going to have to pay, and you're basically making sure people are prepared to know that there's no surprises when they come in for what the cost of their service is going to be. If you stop and take a moment to do this, patients are going to be more informed and they're going to have a better experience. As well, you're going to find when I go to the time of service, when the patient actually shows up, you're going to know more about them, that you're not going to have to hand them a clipboard with a piece of paper that says, can you tell me your name? Because if you did your homework, you actually should know more about them than they know about themselves for a new patient. Now, an established patient, that can be a quick, hey, let me check. Is your insurance this? How do you plan to pay? If grandma's paying for your services, this is the step where we'd call grandma and say, hey, did you know you're paying for your grandson's health care today? So health exchanges come into play here. This is where you're contracting your network participations, your plan matrix of what are the networks I'm on and who am I with. That's where all of this comes into play and takes place. Okay, so let's take a look at what's virtual registration mean. When you do virtual registration, we have something that's called real-time eligibility. And what real-time eligibility is through a computer technology, I plug myself in, hit go, and next thing you know, good Lord, look what I found on myself through my computer system that has nothing to do with me filling out a piece of paper. I'm able to see that I'm on United Healthcare. I got the correct spelling of my last name. Even if it isn't correct, that's the spelling I'm going to use because that's the spelling that Medicare or the insurance company has. I've got provider ID information. You can see I got my group number, I got my eligibility date, I got my plans, my addresses, the payer, I got the plan. I've got everything I need. And in fact, if you load this up in your system, you might know more than the patient. Go into further detail. Real-time eligibility allows me to see I have a $25 copay for professional services to see a physician. That means they're going to pay $25 out of their pocket to see you. in that outpatient practice. If I'm in an emergency, I'm paying $125. That goes to the hospital, not to the doctors. You're still going to end up with a doctor bill on top of that. Okay? So you need to look at what the benefits are. There is nothing then when I'm running this, and this can be is real time. So when I click the button, I can do this with the patient on the phone when I'm registering them and saying, oh yeah, hey, by the way, you have a individual in-network $2,500 deductible, and you're having an x-ray. Well, guess what? That x-ray or procedure is going to fall to your deductible because we're doing it as a service or procedure or imaging. So you need to know how much you're going to pay. And we'll go into that in a minute here. This is data you can get on the computer systems in your offices. If your staff are not doing it, well, that's not a good thing. So going back to my $2,500 deductible, I'm going to have a procedure done, and the charge is $900, but how much does that patient really have to pay? Well, let's go back. Remember this grid and this slide? I know, let's say it's Blue Cross Blue Shield of Kansas City Freedom Network, I have a $72.23 as my allowable amount. That's what I'm going to collect against the $2,500 deductible for that procedure. And if it's Medicare patient and they've not met their annual deductible, I'm going to take $55.08 from them. So this drives what I should be collecting from the patient and telling grandma on the phone, hey grandma, saw you didn't meet your deductible with Medicare. It's January 6th. I want you to know when you come in, you're going to be paying $55.08 to us to meet your deductible. Then after that, we're going to go to co-insurance, but you need to know that I'm going to expect payment from you on that unless you have a secondary insurance. But if you don't have a secondary insurance and you're just straight Medicare, I need to collect that from you when you come in, so expect to pay that. Have I even seen the patient yet? No. Haven't seen the patient, haven't talked to the patient. So you think, all right, well, this isn't too hard. Well, then you get stuff like this. Here's an actual ID card, and it has big old MetroHealth in the top left corner. But look at the bottom. This is not affiliated with MetroHealth. This is an actual ID card. So the folks that, and I'm not calling them the front office staff. These are truly financial coordinators that you should have in your practices. This isn't the person greeting people at the front counter. Those are greeters. This is, I need insurance people that know what the heck's going on, understands what a network is, understands what the TPA is, understands that I have to have medical management criteria for authorizations to do imaging, that I need referrals to be seen, whatever the rules are for that insurance plan. And I need to know where to send the claims. And I've got to do it right at the front end. Otherwise, what's one of my characteristics? Am I going to reduce the costs in collections and maximize reimbursements? No, because I'm going to send claims to the wrong place. I'm going to get denials. I'm going to have to work them. I'm going to have to do all this extra paperwork, where if you just got it right at the beginning, took the extra time to do your pre-service virtual registration stop, you'll be amazed at how much money your practice would generate. So it's those types of things. And you can say, well, in a practice that makes sense, but do hospitals really do it? Absolutely. That's what the whole admission office does. The admissions office and the pre-certification and the call you ahead of time when you're getting ready to come in and be admitted. Obviously, emergencies are different. This is what we're going to find out. This is what that person standing in your exam room in the emergency room after you've been seen by the doctor and triaged is doing. They're saying, I need to vet through this and make sure I get the claim to the right spot and understand what needs to happen. So all of this gets done before the time of service when I'm going to see the patient. If you do your homework, you get a good grade. Grade translates to the cash. Plus, there's no unexpected expectations. So what happens then when the patient shows up? Well, we went through the place of service options. So you remember that slide where we say, where are you? Am I in an outpatient hospital? Am I inpatient hospital? Am I office? Am I an FQHC? Am I a rural health center? All of those options. We went through that. Nursing homes, things like that. I have a greeter versus financial coordinator. Doctors tend to confuse the two and think that a greeter can interpret and manage the business of the practice. One practice, and I'll give you a quick example. The hospital employed practice, we had just a high volume. We had a person that was trying to answer the phone, schedule patients not well, not a good first impression, collecting insurance money, the front desk person, if you will, that everyone kind of tags as the it person, was just not getting the job and not functioning well. We went and got one of the volunteers at the hospital, one of what we call the redcoats, volunteered at the hospital, came into practice, and we told the volunteer, your whole job is to stand at this window in the waiting room, greet every single person, make sure they're having a great day, figure out what magazines they want to read, make sure they're not sitting in that waiting room longer than like 15 minutes, and keep that place moving. Meanwhile, the financial coordinators banging it out with the insurance companies, running real-time eligibility, getting people on the schedule, doing the homework and things that are necessary to get paid. But that's not a greeter. That's a financial coordinator type position. Notice the difference. Hospitals, you have greeters, you have people that greet you right at their welcome desk, the information desk, always volunteers. Where's the financial coordinators? Those are the admissions people sitting at the computers and getting the data accurately in the system and making sure that hospital is generating revenue for that NICU baby and for the kids that are on that floor. So it's that type of an analogy. Administrative compliance. This is where we sign the paperwork. This is where we sign our assignment of benefits, our financial policies and procedures, our privacy notice. And in fact, I've added a module to our series. I promise it'll be a short one. That is going to go over the financial policies and procedures of a practice, which is essentially when you sign that paperwork at a hospital to get admitted, you never read it. It's like signing for a new car you purchase. You just sign everything. But that's where you're signing all these, appointing you as an agent to fight appeals, assignment of benefits, the authorization to treat, all of those things you're signing. Your practice does the same thing. Where is that form and what's the data? So in putting this slide presentation together, I came up with that would be a really cool thing for us to look at. So we're going to look at that in a future module I'm going to add. Probably I'll swap out one because we're not going to do extra work. Funds management. I'm collecting the money. And oh, you should know how much I'm collecting because I already called and told you how much to bring with you. And if you left your checkbook in the car, well, my goodness, let me go out to the car with you to get your checkbook. There's no reason you shouldn't have this. Oh, by the way, in many of our practices, we have a podiatry practice that 100% of the patients, if you want to be a patient in that practice, you're putting a credit card on file. And then once I go through your insurance, I will charge your credit card if it doesn't exceed $1,000 against your credit card for that service for whatever your patient portion is. I'm almost at the point where if I'm mailing you a statement, I've screwed up the opportunities to collect money along the way. I had the opportunity at scheduling to point out that you owe us money. I had the opportunity at the virtual registration when I called you before your pre-visit workup and said, hey, I did a wallet biopsy and you owe us money. I had an opportunity to collect and pay payment right there. I can take check by phone. I can take credit card by phone. I'll take payments on a payment plan, but you're going to pay. And then when you're standing in front of me, here's another opportunity for me to collect. Pre-visit, after the visit when you check out, something like that. Appointment status, when you arrive, do not sign a piece of paper that's sitting on the counter. I cannot stand that. You should have an electronic medical record that you're checking the patient in. Patients shouldn't have to sign a piece of paper and then because of HIPAA, you're then tearing off the signature name. That's just insane. Ditch that process. It's not patient friendly anyway. Check the patient in the computer and just say hello and be nice to them in that regard. Also, when you start giving patients, say it's a new patient. Well, I've already gone through real-time eligibility. I already know what your insurance is. I already know who you are. I've already spoke to you on the phone, got some demographics. So why on earth am I going to hand you a clipboard with a bunch of papers attached to it that has the first question, put your last name on it? Seriously, that is so uncool. You should be printing out those things already through a mail merge feature of most EMRs and handing patients complete information saying, can you just check to make sure all of this is accurate? You're double checking final time before we start sending charges out that everything's accurate the way we have it because we want to make sure we get paid. Not ask them for initial information. Totally against that. Charge capture is important at time of service. I want that patient in, and before they leave, pay attention, nurse practitioners. Your charting and super bill, if you will, inside the EMR should be done before the patient walks out. Because if I need to calculate what the deductible is or co-insurance that I need to collect on the services rendered, you have to have your charting done. I don't want it done in the next 48 hours. I don't want it done in the 24 hours. I want that charge generated by the time the patient leaves because I need to collect money. So we need to make sure your appointment types, the time it takes you to take patients, and your skill in knowing how to use the EMR are proficient enough that you can get that done because I need to get the money in the door. So charge capture is a big thing. And oh, by the way, I want you to capture everything you did. Just a visit isn't good enough. If you did smoking cessation and you counseled on smoking for 3 to 10 minutes and you meet the criteria, I want it billed. Now, I shouldn't say billed. I want it captured. Is it billable? Don't you worry about that. You chart and do everything you did, and then let the business office figure out what's billable, what's not billable, what's non-covered, and whatever the standard protocols for consistency are to say these are things of the way we do business. Rendering first and billing provider. Incident 2, shared visits. If I have to bill for a commercial carrier under the physician's name as a collaborator, I want a second provider ID number. So I have provider 01, which is doctor collaborator. I have the nurse practitioner who I can bill individually, independently, services to commercial payers, Medicare and Medicaid, 02. And then when I have to bill, because Cigna's stupid and says I have to bill under the collaborating physician's name, and that's just the way we want it, that's not illegal or wrong, it's that commercial carrier's rules. I want an 03 doctor collaborator, but I know 03 was work I, as the nurse practitioner, did. 02, when I add to it, 02 and 3 is my total work effort. 01 is the true doctor. If you go to a medical-based practice where they go, oh, well, when we have to bill under the doctor, we're just going to pick 01, who's getting the work credit for that? Back to that RVU. Who's getting the RVUs or the credit for that work? The 01. And then the doc's can come in and say, you don't do anything here. Look at your numbers. Your numbers are so low. Look at me. I'm a superhero. Well, half my stuff is billed under you because of rules on the commercial carrier side. So you need to push the business office to set it up where doctor is number 1, nurse practitioner is number 2, and then number 3 would be when the nurse practitioner has to be billed under the doctor. Keep the data clean, and now let's look at who's doing what. So that's what we talk about when we talk about rendering and billing providers. That's unique to advanced practice, so that's another one of those little things you need to recognize. And then, of course, recall, procedure, referrals, things in that regard all happen at the time of service. So we talked about, and obviously, if you've not noticed, the yellow areas are what we're now going to talk about a little bit more in depth. Place of service, this slide should look familiar back from the other presentation. These are all the unique places. And remember, every one of these have different rules that change the entire revenue process about what needs to happen when because of the uniquenesses to the rules of each of those. We then have, how much do I collect? Well, now here's an interesting situation. Pay attention. All right. I have a $1,000 in-network deductible that I haven't met. Actually, I should have made the $2,500 in my thing because it's a number, but say I had a $1,000 in-network deductible not met. I have a procedure that does not fall to a copay, but it's going to fall to my deductible. Well, remember back in our how much I get paid, and I wanted to see all the Bass Pro Shop employees because I, as a practice, would get paid $83.23. And oh my gosh, I sure wouldn't want to see Exxon or Houston ISD employees or Health Associates employees because I only get paid $51.61. Well, now the tables are turned because all of a sudden, remember back on that charge slide where I talked about the how much do I have to pay? If I come in as a Bass Pro Shop employee who's under the Employers Health Network, remember the networks where your contracts are held, I'm going to collect $83.23 from you for that procedure. If a Health Associates employee walks in because they're covered under Aetna, and Aetna basically bottomed out their contracts with the doctors and were very aggressive and could use their market share, they're only going to pay $51.61 for that exact same service because they're under Aetna, and that's the network. Because you apply to your deductibles or you calculate your coinsurances off of the allowed amount. So when you're a doctor, I only want to see the Bass Pro Shops and the Ducky Bobs because that's where I get paid the most. But at the same time, if it falls to a patient's in-network deductible, think about high network deductible plans. 100% of that bill is the patient's responsibility. Well, I'm not walking away from $83.23. Because when Bass Pro Shops employees signed on, they knew what they were getting. But Medicare, grandma's going to pay only $60.75 for the exact same service, or Health Associates $51.61 because they pay for that network. So it's interesting how, I'm hoping you see it's interesting how what pays well is great, but it also becomes the patient's responsibility when you start talking about high deductible plans. This is where I'm going to want credit cards on file. I'm going to want to collect ahead of time, and I'm not going to keep this bill out there because I'm not sending you 19 statements to collect $83. I want to collect it ahead of time. Or at the time of service before you walk out the door, which is why you have to have your chart done and the charge is entered so I can know for this procedure that you did while the patient was here in our clinic, they paid this amount. All right, let's talk about charge capture. Show your math. What did you do? I had an office visit, 99212. What was the reason when I scheduled my appointment I put in as my chief complaint? I called up because I was an established patient and I had a sore finger. Sore finger. Then, once I had my sore finger, I went in and I had this great nurse practitioner look at my finger, used medical decision making, performed an exam, and took a little bit of history about it and documented and said, yep, you have a wart. I'm diagnosing you with a wart. And then, as a result of that diagnosis of a wart, I'm going to destroy it. So, did I come in the office with a wart? No. Did I come in the office just to have a wart removed? No, you had clinical decision making to make the determination it was a wart because you came in with a chief complaint, which was the appointment type at the time of the service of a sore finger. So what this is showing you is I have a office visit tied to the first diagnosis, which is a sore finger. Then I have my wart removal, the 17110, tied to my diagnosis number 2, which is 078.10, which is a wart. Now, where you end up having troubles is you have practices that will put the 99212 and the 17110, and over in that diagnosis codes, they're going to put 1,2 and 1,2, or 1,2, 3, 4, or to 12, or 112, or whatever. Well, when I get that as a health plan, you've just basically said, here's everything I did, office visit and wart removal, and here's all the reasons I did stuff, sore finger and removal of a wart, or sore finger and a wart, and I'm going to say, you decide what you want to do. So I, as a health plan, I'm going to say, since you weren't specific in your coding, one-to-one mapping I call it, I'm going to say that the office visit was for a wart, and you had a wart removed you removed a wart for a wart. So really the patient walked in with a wart, you burned it off, doesn't justify the office visit. So we're going to zero out the office visit charge. I'm only going to pay for the removal of the wart. Have a great day. Had a high-risk OB HIV doctor that was just screaming about the health plans and they're just ripping them off and blah, blah, blah. And I said, let's look at a claim. And he did just that. He threw out all the things he did, he threw out all the reasons he did, and let the carrier match them up. Well, guess what? They're going to match up that I had a sore finger, and so I had a foot x-ray. Doesn't even make sense. Denied. I had a smoking cessation counseling because the person had a wart. Doesn't even make sense. Medical necessity. Denied. So if you don't map the why'd you do it to what you did, one-to-one, you don't get the A. It's just like a math problem. You might come out with the right answer, it was a wart, but you got to show your math. You got to show the math to get the A. You've got to have one-to-one mapping and show your work to get the money. So that's a lot of times when people say, oh, well, they never pay for an office visit, they only pay for the procedure. Not necessarily, that just means you're billing it wrong. So those are ways we find more money. ICD-10, not such a scary thing. I think it's a little bit of a Y2K phenomena. Granted, I understand there's a lot of work and programming that went in, but if you have the right software, it's going to pick up and say, hey, you said you had rheumatoid arthritis. Let me ask you a question. Was that, where was that? Was it the right shoulder, left shoulder, unspecified shoulder? And you're going to say, hey, it was the right shoulder. And then it's going to say, hey, one more question. Is this the first time or second time that's been seen? And the system should prompt you to get to the right ICD-10 code. So just not a big scary thing. Crosswalks exist. But again, this point is show your math when you're capturing the charge. All right, so I scheduled, collected money. I called ahead of time, pre-service visit, virtual registration, confirmed my networks. I got benefits. I know you're covered. I know you have a $20 copay. I know you have deductibles. I can collect money. I had a time of service. You stood in front of me. I had 2 opportunities to collect money. Once when you arrived, once when you left. Have the opportunity to capture charges. Make sure you capture everything you did. And I don't care if it's billable or not billable. Another example, Aetna. Aetna had come out and said, hey, we're not paying for EKGs during an office visit. We're making that an integral part of the visit, and that's our rule. And so one practice manager goes, well, they never pay it, so we're never going to bill it. Well, guess what? Class action lawsuit comes out. Aetna comes up, gets basically cited and said, no, you have to pay for the EKGs. Aetna said, well, if the providers bill the EKGs, we'll reprocess those, change our policy moving forward. That office manager just cost that practice every EKG because they said, well, just because they don't pay it, I'm not billing it. No, you get it in the system and you put it out there because you never know what's going to stick, or if it's not paying, what class action lawsuit is going to come down the pike later, and then you're going to end up with a nice check for that. So another example where they go with that, they never pay it, so I'm never billing it. No, I don't go for that. So I've had 3 opportunities now to collect money. Well, now we're kind of locked and loaded, and charges are going out the door. So charge posting. Got to look at the census. Do I have charges for everybody that was seen in the ER? Do I have a charge for every baby that's in that NICU? Do I have a charge for every patient that was on that schedule today? We know from the last module, see how it's integrating? We did a charge analysis. There's 1 charge. We know how we got to that charge. And we do service capture, not just services billed. If you did it, you document it. Did you do a phone call that was medically necessary where you altered the treatment and the patient was not seen in the last 7 days and they're not going to be seen in the next available appointment or 48 hours or 24 hours? Then you document it and you bill it through. And if you get paid your $13.29 from Aetna, awesome. Medicare is not going to pay you, but you know what? You still clock the work effort and show the value for the service you're providing. Retail charge posting. I sell diabetic lancets in my office, and there's a way to post those charges. I sell orthotics. I sell equipment. I sell retail stuff. I have Botox. I do all kinds of retail stuff. You still sell it. It's non-covered service. The patient knows ahead of time. You collect the money. All is good. So, claim scrubbing. Here's my chance to really fix things. I'm going to be looking at 7 different things. I'm going to be looking at integrity testing. Is a date of birth a valid date of birth? Or was the person born in 2017 that hasn't even happened yet? I'm going to look at financial edits. Does every line item have a charge attached to it? Did they load it up? I'm going to look at situational testing. Do I have a chest x-ray on a diagnosis of sore finger? No, those things are going to get kicked out. I'm going to make sure that my LCD edits or my medical necessity edits are passed. I'm going to look at special lines of service on allergy testing or pulmonary testing, and then I'm going to have payer-specific edits that I'm going to load to make sure that, hey, if I have to bill a nurse practitioner service where the rendering provider is the nurse practitioner, I may need to put an SA modifier in there as a modifier because Blue Cross Blue Shield requires that. That is a payer-specific edit. If you have a true claim scrubbing, and do not come to me and say, oh, well, we have a clearinghouse and they edit our claims. No, they don't. They do like the first 3, the syntax, the requirement testing, and financial edits. They don't do the other most important ones. And so this is a chance for you to really make sure you got your ducks in a row and things together, because right now I'm getting ready to send that claim out the door and submit it to the carrier. And the last thing I want is something other than payment. So we've done a lot of good work up to this point to make sure I get paid the first time. So we're going to take a little bit closer look because I want to show you just a couple screens examples of what those edits mean and look like, at least in one system. And then we talked about legal authority to bill. Why are you as a nurse practitioner allowed to even bill for services? And we understand that. So those all fall into that charge posting and send it out and get it right. Okay? Look how important. The missing charge audit. I got on there twice. That's how interested I am in that topic. All right, so scrubbing it. Right here. When I went through and scrubbed my claims, look here. 1, 2, 3, 4, 5, 6 kicked out and said, you cannot bill these. You got to fix them before they go out the door. Now, if you didn't have a scrub edit in place, those would be gone. 30 days later, you might get a letter that says, hey, we can't pay this. Don't recognize the patient. Date of birth wrong. Makes no sense. Denied claim. Then you're going to have to put it in your work queue. Then someone's going to have to touch it, $25 later in effort and resources, they're going to resubmit the claim. Now maybe you're 60 days out trying to get paid, where right here you fix it before it goes out the door. The green X's, all passed. You know those are going out. They are clean. I've run them through essentially the edits the payer is going to run them through when they get it to make sure that claim is clean and can be spun through the system and pay us in 14 days. Yellow, you may want to look at those. It passed the edits, but there's some things that might be a little quirky on it. Well, one thing that can come up right here. If other subscribers present, then the other subscriber's birth date's required. Well, I need a subscriber. If I'm not the subscriber, I need the date of birth. So if I'm a pediatric child and I'm on mommy's coverage, I need mommy's date of birth in my computer system and demographics to make sure I can get paid. So those are the types of edits and things that'll come up. So I've got my charges out. When charges go out, what comes in? Money. So payment posting. I do not want checks. And in fact, the Affordable Care Act has done one really nice thing, which is standardized and said, nobody should be getting checks by paper anymore. This should all be done online. We also know that I think it's 97, 98%, we'll have to get to that, if consumers want to pay their medical bills online. Stop sending mail. Just stop it. And so this is the process where we have to make sure you fill out the EFT, the electronic fund transfers. We make sure that we're getting our ERAs or our remittance, our EOBs electronically. And we want to use technology to have these files transfer back and forth to help us post. Also, when I get an ERA, I want to know, go back to Bass Pro Shop. Okay, say that deductible was met and they're going to pay me my $83. Well, I want that reimbursement matrix going to say Employers Health Network. I won't necessarily have Bass Pro Shops, but I'll say Employers Health Network is going to pay me $83 for the service. When that ERA comes in and the EFT comes in, by God, there better be an $83 allowable on there. Now, I might not get the $83 check because of deductibles or co-insurance or things like that, but that needs to be my starting point. You got to monitor and look for those payment exceptions. The $50,000 fine. I was so excited. Our practice and staff realized we were getting underpaid from Blue Cross Blue Shield, to the tune of, within a short time period, they captured an additional $50,000 for a solo practice, a physician and nurse practitioner. They captured an additional $50,000 because they were paying attention to, hey, reimbursement matrix says this amount, money's not coming in and the allowables aren't at this amount. Went back, guess what? Blue Cross is like, hey, we need to fix that. And so we got an extra $50,000. How many of your practices or people do you think, hey, we got paid, I posted the adjustment, I moved on with life, coffee at 12? No, you got to pay attention. This is your money. Remittance address. Do not use the physical address of your hospital. Do not use the physical address of your practice. Never use your physical address. Use a lockbox. Spend the extra money, get a lockbox. Use a P.O. box. You never know where your practice may move or expand. Do not use your physical address. Once you get your remittance address locked in with a plan, it's going to take forever to change. And the reason is, you go to Aetna and say, hey, Aetna, we update my remittance address. Aetna says, absolutely, I already updated it. Well, they got, 6, 7 different systems that overwrite each other, and you got all kinds of stuff going on. Next thing you know, that got overwritten, and you're stuck. So, remittance address is always a lockbox or P.O. box. That's essentially like a lockbox. Future payment exceptions, well, hey, what's coming down the road? We know, global periods, we've talked about that. They're talking about getting rid of the 90-day global where I do surgery and everything I do for the next 90 days after that surgery is included in that surgery's package. Well, they're talking now that that's going to get dismantled. We know that we get pay for performance. We're looking at outcomes data. We're not looking for every time I see a patient, I'm going to get paid. This is where we come into, hey, nurse practitioners, this is a huge opportunity for you to go in and really manage the care of a population for the benefit of outcomes-based reimbursement. That's where we're headed. Well, those are the ways we bring payments in. We also get interest payments. Medicaid health plan doesn't pay us timely. We get an interest payment. We get bonus payments. Those are all things you post into the computer system that you have to have rules on. And obviously balance with the bank. You're probably sitting there thinking, well, if they send me electronic funds, and then the ERA paperwork and the EFT was $1,000 and the electronic EOB I'm getting is going to have $1,000 too. Well, wouldn't that be nice? No, it doesn't always happen that way. And in fact, the funds can come a day or two before the electronic file, or the electronic file comes before the actual payment arrives. Well, you got to pay attention to what's going on in that bank statement, because you don't just post ERAs that come in without checking to make sure the money's in the bank. Because then you're going to be at the end of the day going, hey, I posted, $600,000 this month, and the bank only has $4. Well, oh yeah, I guess that EFT didn't come through. No. Payment posting is the step where all that stuff gets caught. Separation of duties, segregation of duties. If you collect money at the time of service, I collect $20. That patient or that employee better not be posting that payment. Why? Theft. I can go in and post, I get $20. I'm going to go in, post $10, put $10 in the bank, post $10, and I'm going to post a $10 adjustment, take $10 home with me. Don't think it happens all the time. In fact, we got a practice in Houston, Texas, that the front desk person was the happiest person in the practice. Well, why? They embezzled about $60,000 from the practice. And it's very easy. Take cash over the counter, and if that person is posting the payments and posting the adjustments, the patient's never going to get a bill. Very easy for fraud. So keep responsibility and separating duties. If you collect the money, you can generate a receipt, but you're not posting the transaction, because we've got to have some kind of checks and balances. So the fact that that person who's been with you for 33 years and they're just the grandest little person in the world, that's fabulous. But you know what? You need to put some checks and balances, because this is your business that you're taking care of. So what happens after payment posting? Oh, before I do that. All right, so virtual credit cards. What the heck is that? So there's this little rule that came out. The Affordable Care Act has required health plans that said you got to send EFT to everybody. Well, some of the smaller health plans are like, yeah, that's kind of expensive, but wait a second. If CMS has the authority to enforce this, that means I can get fined. So what they've come out with is these, what they call virtual credit cards, and you're looking at one right here. It is a piece of paper that comes in the mail that has a little credit card, and I go and I run that credit card number. There's my security code, there's my expiration date, and there's the authorized amount. If I put in the credit card system $45.58, it's going to decline, because the card's only authorized to pay $45.45. I can probably put in $40 and take it, and there's still $5. Well, what if the practice never processes this? What if, you don't have that? Well, the health plan just saved the expense of issuing checks, canceling checks, doing all that stuff, because now they're managing all through a merchant system. Why does this suck for you? Because when you get a check from a health plan for $1,000, you get $1,000. When you get a virtual credit card payment from a health plan who's complying with the ACH standards that are required of them, because they don't have the cost or expense of the infrastructure to put an EFT, a true EFT system in place, you have to pay merchant fees on that $1,000. So that already horrible reimbursement you're complaining about just got reduced by like another 1.37% in some change. Or actually probably 2%, because this is not a credit card processed with card in hand. So it's those types of things we've got to kind of think about and watch it that you do when you post payments, or payments are being processed in your office. All right, so set all my claims out. Awesome. All the payments came back in for every single one. Well, goodness gracious, wouldn't we all be out of work on my side of the table if that was the case? So we have the step called third-party recovery, or accounts receivable recovery. And this is where we go and say, all right, now we sent all these claims out. We don't know what's going on. We have a couple good things. One, the claim status or category codes, which is called the 276, 277 files. That is your United States Postal Service tracking system, if you will. That allows you to tag an insurance company and say, hey, I sent you 8 claims. I only got 3 paid back. What's going on with the rest of the 5? And then you ping them, which is a 276 request, and then Aetna has to send back one of like 500-600 responses that are going to say, here's the status of what's going on with that claim. If you don't have that pinging option set up with your clearinghouse and into your system, you're likely going to be doing what? Sitting on the phone, listening to music, going through, I can answer 5 claims questions, hang up, call again. How much money and resources are you wasting because you don't have technology in place where you basically have the ability to track claims through your claim status inquiry? We'll go into that because you can see down there it's yellow. Claim adjustment reason codes. Well, when I get a claim back that says, hey, I'm not paying this because of remark code 1, that means it went to deductible. Or is it 95, not covered service? So there's a National Uniform Claim Committee that actually comes up with about 300 different codes that are all the reasons of claims don't get paid, or what's the adjustment reason codes I add to that. Correspondence trending. Why am I not getting paid? Am I looking at all the mail for the month or electronic remittance for the month and going, 99% of my people are getting denied because they're not eligible for services? Well, wait a second. If they're not eligible for services, who's screwed up? Where's virtual registration? What are they doing? They need to be cleaning that up for us. I shouldn't be working it on the back end. Hey, this got denied because the patient didn't have a referral for treatment. Hey, medical management obligation of virtual registration. Why aren't you paying attention? And why did you see that patient not getting a referral? So now you end up with this like us-them battle of, hey, if the front office did this, the back office can collect. Well, it's one process. So one person needs to be over it because you've got to get these pieces working. And if you do it right on the front end, you got to put the energy on the front end. You shouldn't have this number 6 step. This shouldn't be very, very quick to go through. So if you're interested in what all the claims are, the website at the bottom will actually get you to all the code sets and all the rules. But you're lucky because you're in the class, and I'm going to show you a few examples. So what's a claim adjustment reason code? There's about 300 of these codes, and they're standardized. So you can see number 4, the procedure is inconsistent with the modifier used required is missing. So basically the claim got denied because it required a modifier or one was missing or it's inconsistent. So you got to fix that. Well, guess what? Where's your claim editor? When you did charge posting, your claim should have been scrubbed. That should have been picked up. You know, the procedure code type builds inconsistent with the place of service. Where if you get a number 5 and I have a claim editor, someone's going to get hit. Because seriously, if I am billing an inpatient subsequent hospital visit with an outpatient place of service doctor's office, you cannot in a doctor's office do an inpatient service. They don't match. The place of service is inconsistent. Your claim editor, when you sent claims in that charge posting step, should have picked that up. Oh, well, my doc was too cheap. He didn't pay for the claim editor, so we just have to work it on the back end. You're spending more money on the back end where you just put the technology on the front end, it would work for you. So it's that type of back and forth that we end up having a lot of fun with. Claim status, the HIPAA requires that health insurance payers in the United States comply with EDI standards. So that's where they said, hey, guess what? We're all going to start communicating electronically, and we're going to be using these what's called ANSI X12 files. And in this case, I'm happy because it includes the 276 request that gets you the 277 response for where is my claim and what is going on with it. So here there's about 761 responses, and they tell you things like, hey, we received the claim. Okay, that's a really cool thing. You might think, well, that's dumb. That is so cool because if I send 100 claims to Aetna, in a couple days from now, I'm going to want to ping them, and those 100 claims better come back. When I ping them with a 276, I want my 277 response to come back, and I'll have an A1. Well, if they all come back with an A1, that means, guess what? You can't shred the claim. You confirmed you have it. And I'm not going to wait 30 days from now to go back and figure out you never had the claim on file and have to file it again. These are all delays that you just can get rid of if you just get your shop in order. The claim was rejected. Okay, great. I know what I need to do. It's missing information. What do you mean it's missing information? If it went through a claim editor, that A6 better be happening. Claim was paid. F1. I love F1. And let me tell you why. That means when I have an accounts receivable of $200,000 and my staff can come to me and say, hey, we have an AR of $200,000. Claim status inquiry shows that $100,000 of that's in an F1 status. I know the job's getting done. It's not going to show in the AR because that money's not arrived yet. So think about what I just said. I should know what's going on before the mail and electronic files arrive. Because if you're on top of your accounts receivable, I should be able to grab any one of these 700 and some codes and know exactly what's going on in my accounts receivable. There's no guesswork. There's no, well, I don't know, let me just see what came in the mail yesterday. The mail is just merely confirmation of what you should already know. You should know I got $100,000 of money coming out on those claims. Claim denied for waiting on EOB. Secondaries wants the EOB information. Pending payer review. Payers reviewing pending claims for determination. Okay, we call that delay. So I'm going to be all over that and figure out what are you reviewing that I can help with. Patients to supply information to insurance. Well, guess what? If I find out I send a claim today, it's Monday, and I ping this and I get a P4 back on Friday that says the insurance is requesting information from the patient, insurance amount to be moved from insurance status, patient responsibility pending action by patient, which is my action in my practice. I'm going to dump this to the patient on Thursday, put an automatic call out to them and say, hey, guess what? This insurance process didn't work because they need something from you. And I'm putting this balance onto you because until you answer your insurance company, they're not paying me. So guess what? Until you answer them, I'm not moving it back. So those are the types of things that you can find out. This is how a business office operates. These are the tools and resources you have to make this work. All right, end of the day, somebody screwed up. They didn't collect at scheduling. They didn't collect when I did pre-service. They didn't collect at the time of service. And now there's a balance due because Bass Pro Shop's procedure got out the door. I now have to mail a statement. That's 49 cents plus the extra effort. It's about 72 cents to mail a statement. I mail 3 statements. My God, you're dipping into a couple dollars just to ask a patient to pay you when you had how many opportunities to get payment? Now I'm going to pay to send a patient a statement. And I also have this at the last step or near the last step because do I send a statement to a patient after the primary insurance pays and say, oh, I'm sorry, our computer generated statements. I'm sending it to your secondary. Just ignore that statement. What are you teaching your patients? You're teaching them ignore mail I send to you. So you need to make sure your primary insurance is exhausted, your secondary, all your insurance pieces are done so that when you get a statement and they pick up the phone and call and say, hey, I got a bill, I need to know if I need to pay it, my answer is absolutely, and I can guarantee it. Because I know we're done with everything. Not, well, let me check and see. Oh, yeah, we're billing your secondary. Sorry about that. So the next 5 statements are going to be like, they billed my secondary. No, you gotta train the patients to know you pay me when you get something. Besides, you should train them to collect ahead of time, and I should never have to mail a statement if I have a credit card on file, because whatever your responsibility is, I should be able to charge a card and call it a day. Thanks very much. Let's move on to the next patient. This is a business. You need to get paid. Your hospital you're employed by, your employer needs money. You need money. This is the process we have to go through to get paid. Service discounts. We had a whole module on medical service discounts. When now can I discount my services because, oh, wait, you have hardship or indigency. And we went through when you can and what the legal ramifications are around some of those things. What are your obligations and how do you do that? So we know about that now. And InstaMed's 2014 Trends in Healthcare say 93% of consumers want to pay their healthcare bills online. The doctor goes, well, I don't have that feature set up. Well, get it set up. Why do you want mail that people have to touch and manage? All your stuff should be coming electronically for funds payment. Patients want to pay you online. Give them the option to send them an email with a bill that has a click pay now button. And if you don't have your merchant services able to do that, then stop getting your merchant services from banks and get your merchant services from companies that focus on healthcare where those features are available, where they can pay in the patient portal and they can pay online. And our healthcare merchant services, not, oh, it's the merchant services that was sold with my bank. My bank when I set up the account. No, you got to focus on that. All right, so I went the whole way around the circle. And by the time I'm the whole way around that circle, I better have all my money in the door. But now I'm going to stop and say, wait a second. How am I doing? Are people just writing stuff off randomly that I should be getting more money? Are my charges skewed? Am I finding that level 4 visits are not being billed a lot and level 2 visits are being billed? This is where I hit the quality assurance and compliance. Do I need to do a few chart audits so people can look at it and say, hey, you're missing charges. This isn't working well. Every month I want to look at what are my outstanding charges? Why are they outstanding? What's going on? I want to look at my performance indicators. How many days in accounts receivable do I have? What's my AR ratio? What's my gross and net collections? And now you're probably going, well, what does all that mean? And happy, we're going to have a whole module on that alone, just on the performance indicators and how to look at your books and know what's going on. So another fun module that we're going to deal with. And so we also here look at complaints, grievances. You know, when you get a patient that calls up and says, hey, I got a bill and I never had this service. okay, what do you mean you never had this service? So now we got to go pull the medical record, and are we fraudulently billing? We can't bill for dead people, things like that, which is, if you remember the slide back here on charge posting, kind of goes back to this slide right here. And now it'll make a lot of sense, because when I send my charges out, lodging, next right, state prison, because if you start sending charges on dead people, you start sending fraudulent charges, you start sending up charges, you're upcoding. Those are all things that are going to get you in all kinds of hot water. Well, where do you internally self-monitor that so you don't get caught? Right here in your quality assurance and audit and compliance area. So that's where that happens. So before we go on, I have a great analogy I want to run through that I think will help crystallize and pull this all together. And before we do that, I think we've hit on pieces of the puzzle that, we achieved our kind of goals here. So I'm going to stop here. I'm going to do a next video that's just going to do the analogy, and we should be done. Thanks.